Good morning, everyone. Good afternoon, Benjamin. Bonjour. I thank you, everyone, to be here. Fernanda Baião, Benjamin, Jorge, Boza, and Igor for Igor's PhD Viva. So it's a pleasure to be here with you. Thank you so much. And Igor is going to present today his final stage of his PhD. And the title is Essays on Length of Stay Prediction in Intensive Care Units. Some of you know some parts of this work. And please, I am the supervisor and Professor Silvio Hamacha as well. So thank you, Igor. The floor is yours.
Thank you, Sereno. Good morning, everyone. Bonjour, Benjamin. My PhD thesis is about length of stay prediction in intensive care units. My name is Igor Peres, and the advisors were Professor Fernando Sereno and Silvio Hamacha. So the length of stay is commonly used as a surrogate of cost and efficiency, and typically reflects several aspects of care, including admission and discharge policies, adherence to best practices, and patient safety. So the main reasons for hospital administrators to predict the length of stay are plan the number of resources required, identify patients with greater risk of prolonged stay, and enable case mix adjustments for benchmarking analysis. So first of all, we want to propose a structured data-driven framework to achieve the main ICU manager's demands. And the specific objectives is we want to propose a methodology to predict the individual ICU length of stay, which can be used to plan the number of resources required, predict the risk of prolonged stay, which helps identifying the prolonged stay patients and drive quality improvement actions, and to propose a methodology to perform benchmarking analysis between ICUs. The thesis is organized as follows. So first we, in chapter 2, present a systematic review of factors that predict patient length of stay in ICUs. In chapter 3, we propose a framework including a methodology to predict the numeric ICU length of stay, the risk of prolonged stay, and a methodology to perform benchmarking analysis. In chapter 4, we present an application of this proposed methodology in a big set of ICUs. And finally, in chapter 5, we present the conclusions and future perspectives. So starting with chapter 2, we did a systematic review and meta-analysis of factors that predict the length of stay in intensive care units. We searched Medline in Bayes and Scopus databases from inception to May 2020. The searching process focused on papers presenting risk factors of ICU length of stay, and this work is published on Journal of Critical Care. So the inclusion criteria starts with 6,906 papers. After applying the eligibility criteria, we stay with 113 papers for the qualitative synthesis and 28 papers to be meta-analyzed. So the main results of this work, we suggested a list of factors that should be considered in prediction models for ICU length of stay. And the meta-analysis was performed for 6 factors and concluded that mechanical ventilation, hypomagnesemia, delirium, and malnutrition were significant features, while age and gender were not significant. So chapter 3, we will present a data-driven methodology to predict the ICU length of stay. And the main objective was to propose a framework that included the main topics of ICU length of stay prediction. So this is the framework. We start with a data preparation and preprocessing, which is important before applying any modeling. And then we predict the patient length of stay, the numeric ICU length of stay, the individual numeric ICU length of stay, and the risk of prolonged stay. And finally, we perform benchmark analysis between ICUs using the model developed in section 3.2. So starting with data preparation and preprocessing, we follow these steps. First, we did the data preparation, visualization and data cleaning. We split the data set in training and testing, and we applied data preprocessing techniques. Talking about the visualization and data cleaning, we excluded features with more than 30% of missing. We did a descriptive statistical analysis, and we analyzed the presence of outliers. And regarding the data preprocessing, we followed the steps. We first did a dimension reduction, removing 0 and near 0 variance predictors and correlated predictors. We applied imputation for features with missing data. We used multiple imputation by channel equations, MICE. We did a feature selection. We applied the recursive feature elimination to remove features that do not present significant contribution to the model. We analyzed transformations to skewed features. And for some models, we did a normalization to set the numerical features on a common scale and one hot encoding to encode categorical features into binary ones. So the second step was the methodology to predict the numeric ICU length of stay. So we will test the following regression models: random forests, gradient Bayesian trees, bagging, carts, support vector regression, k-near neighborhoods, generalized linear model, and linear regression. So the parameters of the model will be selected in order to minimize the prediction error, which in this case is the root mean square error. Regarding the methodology to predict the risk of prolonged stay, we have two objectives. So the first one is to predict the patient's risk to stay over 14 days following the literature. So it's important because we can identify prolonged stay patients regardless of their diagnosis, and it's important to plan resources and operations. And the second objective was to predict the patient's risk to stay over a specific threshold, defined depending on the diagnosis group. So it's important to predict patients with critical conditions inside the diagnosis group, and this helps to drive immediate care for those patients. About model tuning, we trained using the best performing type of model, a set of features obtained from the analysis of section 3.2. And the parameters will be selected in order to minimize the prediction error, which in this case is the Brewer score. So about to perform a benchmark analysis between ICUs, the traditional measure used by ICUs to evaluate efficiency is the standardized resource use, SRU. However, there's a limitation regarding the use of this measure because it just uses SAPS score. And to overcome this limitation, we used our prediction model to build a case mix adjusted efficiency measure, named the standardized length of stay ratio, SLOSR. So the formulation of SLOSR is very simple. We had first, for each ICU, we will sum the observed ICU length of stay for all patients and divide by the sum of expected ICU length of stay for all patients. So SLOSR has the potential to adjust the expected length of stay by each ICU case mix, since our prediction model considers several relevant features and is capable of performing unbiased benchmarking analysis between ICUs. And in chapter 4, we applied this methodology in a data set with 109 MIST type ICUs. The data represent a set of MIST type ICUs from 38 different Brazilian hospitals, a total of 103,195 admissions from January to December 2019. The complete data set is a join of 5 tables. So we have demographic data, comorbidities, ICU complications, physiological and laboratorial data, and secondary diagnosis. And about the description of the hospitals, where this figure represents the distribution of ICU length of stay for each hospital, where we have 38 hospitals. So we can see that we have heterogeneous hospitals with different distributions, and we cannot see a pattern associated with the size of the hospital. We can see the size of the hospitals in the colors. Regarding the distribution of length of stay for each ICU type, we can see in this figure that most ICUs are general and cardiac. So the most ICUs are this type. And we have few surgical, orthopedic, neurological, and oncological ICUs. You can also see that the distribution of the orthopedic ICU was very different, but it may be associated with the small sample size of this type of ICU. Okay, now I will present the application of the methodology to the dataset, starting with the data preparation and preprocessing. So first we removed the features with more than 30% of missing. I have ICD code and 7 laboratory features. We removed the outliers. And if we look for the histogram of ICU length of stay, we can see that the distribution is very skewed. So I have to do some treatments for that reason. Regarding the data preprocessing, we removed 0 and near zero variance predictors, correlated numeric and categorical features. So in total, we removed 22 features in this step. About the preprocessing sensitivity analysis, we analyze a scenario of grouping strategies to the feature admission mean diagnosis. We originally had 851 codes of diagnosis, and we test to reduce this number for 19 grouped codes or 8 grouped codes. And we also test transformations to the feature ICU length of stay, which is very skewed. So we tested to truncate this feature at 21 days and to apply a box plots transformation. And we also test feature scenario analysis, feature selection analysis. Regarding the grouping strategies, we test the 2 grouping strategies and noted that the results reported, our strategy reports similar results. So we will stay with 8 grouped diagnoses since it reduces the dataset complexity, and we will consider this strategy for our further analysis. Regarding the transformations to ICU length of stay, we tested 2 types of transformations, but the box Cox we applied also for the truncated length of stay. So the truncated length of stay present the best results, and we will consider this strategy for our further analysis. Regarding the severity score analysis, we analyzed the accuracy of the model using only severity scores. So we can note that the results using just this set of features was not accurate. We had in our data set 4 severity scores, the SAPS-3, SOFA, MFI, and Chelsea comorbidity. So if we use only these features, we had inferior results. And these results reinforce the limitation of using just severity scores to predict the ICU length of stay. We also did a feature selection analysis. So we first analyzed a scenario applying the recursive feature elimination for the completed data set. The algorithm selects 26 features, and the result was closer to the model with all features. So we have a very close result. And we also test a scenario applying the recursive feature elimination for data sets without severity scores. So the algorithm select 28 features, and we also had a result almost equal to the previous scenario. So we decided to stay with the scenario without severity scores, since these features are correlated to several other features. And the model will stay with 28 features selected by the algorithm, and we will consider this strategy for our further analysis. And after preprocessing the data set, we can apply our prediction models. So first, about the prediction of numeric ICU length of stay, we applied our models, and we can see that random forest presents the best result. If we analyze the calibration of random forest, we can see in this figure presents the distribution of predicted and observed ICU length of stay. So you can see that for all testing sets, the overall predictions are small overestimated in blue. And if we analyze it, this overestimation only occurs for the range lower than 3 days. The best calibration is in the range 3 to 7 days. And the predictions bigger than 7 days tend to be underestimated. And it's a phenomenon very common in the literature because it's very difficult to predict the prolonged stay patients. So it's very common to be underestimated in this range. So about the prediction of the risk of prolonged stay, we propose two models. Model A predict the risk of a patient to stay over 14 days, and Model B predict the risk of a patient to stay over the 90% percentile of his diagnosis group. So in this case, we will use a variable threshold depending on the patient diagnosis. For example, for community-acquired pneumonia patients, the threshold will be 17 days. For chest pain patients, the threshold will be 5 days, which means that patients with chest pain will be considered prolonged stay if they stay more than 5 days. So the results of the both models, the application of both models, we have that both present accurate results compared to the literature. We have a low risk score, 0.05, and high area under the curve, positive predictive value, and negative predictive value. And we can see that Model B presents inferior results compared to Model A, but still an accurate result. Regarding the calibration of Model A, we can see that first, this table presents the range of predicted risk, the observed prolonged stay patients in each range, and we want to see the proportion of prolonged stay patients in each range. So we can see that low and moderate risk patients include few prolonged stay patients, which is the effect that we want. And on the other side, we can see that high and very high risk patients included a great proportion of prolonged stay patients, especially the very high. We have almost all predicted patients as real observed prolonged stay, which is a very good accuracy of our model. So the results show an accurate calibration for the prediction of the risk to be a prolonged stay. Model B presents a similar behavior, almost very close to Model A, so we can consider this model validated too. Okay, about the application of the methodology perform benchmark analysis. To estimate the SLOSR, we need to obtain the observed and the expected ICU length of stay for each ICU. We used our model to estimate the expected ICU length of stay, and we can analyze first the calibration of our model to predict the group length of stay. So this figure represents the calibration of the model. We have the sum of predicted ICU length of stay and the sum of observed ICU length of stay. So we can see that the model presents a high coefficient of determination, 0.993, it's very high, and the model predicts accurately small and big ICUs. We estimated the SLOS ratio for each ICU. So to check the calibration of SLOS ratio, we used the FUNA plot. So FUNA plot is commonly used to analyze the calibration of models. We can see that most ICUs were inside the control limits, more than 80%. The overall SLOS ratio, which is this line in black, was 0.99, which is very close to the reference, which is 1. So the results are an accurate calibration for the SLOS ratio. And I bring here an example of how to compare ICUs, how to benchmark ICUs using SLOS ratio. We can look, this table shows the number of admissions, the sum of observed length of stay, the sum of predicted length of stay, and the SLOS ratio for each unit code, for each ICU. And I divide it in efficient and non-efficient ICUs for general ICUs. So we can see that, for example, ICUs with similar admissions, like 100 admissions, and with similar sum of predicted length of stay, behave differently. So for efficient ICUs, we have a sum of observed length of stay lower than the predicted. And for non-efficient, we have a number greater than, higher than the predicted. So as loss ratio, we will just report this measure. So efficient ICUs will have S loss ratio lower than 1, and no efficient an S loss ratio bigger than 1. Since our prediction model is accurate, we can give an accurate information of S loss ratio to ICU managers. With this measure, they can identify efficient and inefficient ICUs and then analyze the possible causes for that. So S loss ratio is a very relevant source of ICU information. And one interesting conclusion here is we have in our literature review, we propose a list of risk factors of prolonged stay patients in ICU, and we can compare with our model, the predictors of our model, and we can see that some predictors in our work were also in our review, which was the body mass index, the Glasgow was one of the most important in our work, the admission source and admission type, the mechanical ventilation, which is very important too, it's a very important feature, chronic cardiovascular disease, reasons for ICU admission, body temperature, and we have also to consider that our model has another features. So we want to recommend for the literature to test other features that we found in our work. So we found for patient demographics that age, length of stay prior to unit admission, gender, vasopressor, and non-invasive ventilation as important features. For comorbidities or clinical conditions, we have dementia, frailty, angina, alcoholism, and ages. For chronic health items, we have chronic renal failure, acute atrial fibrillation, and acute kidney injury. And finally, for clinical information or laboratory information, we had also urea, leukocyte, creatinine, heart rate, respiratory rate, and bilirubin. So this thesis has the following limitations. The prediction models were trained considering the year of 2019, not include COVID patients. The application represents a data set of Brazilian private hospitals. And for future studies, we recommend to evaluate the adherence of prediction models after including COVID patients, to perform an external validation in a different data set, and to incorporate temporal features to the problem in order to get the evolution of the patient. So these are the publications during the thesis, and that's it.